بص هتلاقي في الاتنديس دكتور البهي ربنا يعلم.
يا دكتور مع حضرتك.
انا الدكتور خالد الباقي، سامعني؟
اهلا وسهلا بحضرتك يا دكتور.
ازيك يا حبيبي؟ انا كل ما اعمل ستارت فيديو يقول لي ان انت مش فاتح الفيديو لغايه دلوقتي.
كده المفروض اشتغل، حضرتك جرب كده.
انا
تمام.
ظهرت اهو، تمام. طب سامع صوتي كويس؟ يا أحمد،
تمام يا
سامع
دكتور.
صوتي؟ احمد
تمام يا دكتور.
سامع صوتي كده كويس؟
انا سامع صوت حضرتك.
طب كده كويس، سامعني؟
تمام.
طب لو عاوز اخش على الشاشه بقى عشان نبتدي ولا لسه؟
دكتور ناصر معانا.
انا موجود اهو، واحمد مجدي وعمر يوسف.
ايوه، السلام عليكم.
عليكم السلام.
مين معانا بقى؟ مين معانا من الشركه؟
احمد
احمد ايه؟
محمد علي وباشمهندس محمد علي ومهندس احمد مجدي.
عاجبك
احنا لازم
الصوت
نبتدي
حواليا ده؟
دلوقتي.
عاجبك الصوت ده؟
الصوت
ممكن
مش
نبتدي
واضح.
ولا ايه؟
الصوت واضح يا عمر دلوقتي؟
بروفيسور
صوتك واضح.
جينكن,
الصوت هنا.
can you unmute yourself and if you would like to try to share your screen now.
Okay. Is that okay?
It's very good. Okay.
دكتور ناصر، عاوز انا برضه تشير سكرين اطلع عندي؟
Okay. Khalid would like to share his screen to Professor Khalid El-Bahi.
شايفها يا دكتور ناصر؟ انا لسه.
Jenkin, can you stop sharing your screen so that Khalid will share his screen to make a trial?
Okay. Welcome sir.
Respond.
Okay.
Can you see it?
It's very good.
Can you see it now?
Yep.
Okay.
It's very good.
Okay.
Okay, I think it's time to start. Ahmed Magdi. Ahmed, we are going to start now.
Stop sharing, Dr. Khalid.
Okay.
Okay. We can start دلوقتي دكتور عمر.
Okay. Let me now start the session. It gives me great pleasure to welcome all of you in webinar number 9 among the series of webinars organized by the Egyptian Society of Neurological Surgeons in collaboration with the Continental Association of African Neurosurgical Societies. As president of the Egyptian Society of Neurosurgery, and on behalf of all Egyptian neurosurgeons, I would like to express my sincere appreciation for the presence of our speakers, Professor Alistair Jenkins, Professor of Neurosurgery at Royal Victoria Newcastle University in UK, and he is the President-elect of the Society of British Neurological Surgeons. And I would like to welcome Professor Khalid El-Bahi, Professor of Neurosurgery at Ain Shams University and Secretary of the Egyptian Society of Neurosurgery. Thanks to all of you for accepting our invitation and for contributing to this activity. The moderator of this session will be Professor Dr. Omar Youssef, Professor of Neurosurgery at Ain Shams University. For those who don't have Zoom application in their mobiles or laptops, there will be a live stream of this webinar through the YouTube channel of our organization. For all the audience, you can participate by chat questions and we will monitor that through the panel. Now I will give the speech to Professor Dr. Omar Youssef, the moderator, to start the webinar. Thank you.
Dr. Nasser, may I start?
Yes, please.
Yes. Good evening, good afternoon, good morning for all of you. On the behalf of the Jesuit Society of Neurological Surgeons, we have the pleasure to start our international webinar number 9, and we have the pleasure and the honor to welcome our distinguished Professor Jenkins, Professor of Neurosurgery, Royal Victoria Infirmary in Newcastle, UK. Please welcome Dr. Jenkins.
Thank you very
And
much.
we would like to welcome our friend, the Professor Khalid El-Bey, the Professor of Neurosurgery at Shams University and the General Secretary of the
Welcome, Omar.
Egyptian Society of Neurological Surgeons.
Welcome, Omar. Can we start
Okay.
now?
Yes, Dr. Khalid will start his first talk on the craniopharyngiomas approach selection. Please go on.
Can you see it?
Yes, clear, yes.
It's clear? Okay.
Yes, clear.
Can you
Yes,
hear?
clear.
Can you hear me? Okay. Good evening, everybody. I'm Dr. Khalid El-Bey, Professor of Neurosurgery in Shams University. Welcome our guest speaker, Professor Dr. Jenkins from United Kingdom. Welcome, Professor Nasir El-Ghandour and my dear friend, Dr. Omar Youssef. And we can start our topic about the craniopharyngiomas approach selection. Okay? Okay?
Okay.
Yes, start your screen, please.
Okay. Can you see the screen?
Not yet.
Can you see it?
Yes. Okay now. Okay now. Go on.
Can you see the screen? Okay.
Yes. Okay. Go on, please. Yes.
Okay.
Go on.
Okay. Now we'll start our general topic about the craniopharyngioma selection of approach. But before our speaking, we must know some facts about the craniopharyngioma, about the origin of craniopharyngioma and topographic classification of craniopharyngioma to understand how you select your approach. Craniopharyngioma, as we know, arises from the remnant Rathbun's cleft pouch and it represents about 2 to 5% of all intracranial neoplasm and common in children and reaches up to 5 to 15% of all pediatric tumor. And as we know, there is two types, the mentomonatus type, which is common in children, and the papillary type, which is common in adults. Actually, there is no correlation between the pathological types and the rate of recurrence. In past, it's thought that it is common for the mentomonatus type to be common for the recurrence, but actually now there is no difference in the recurrence rate between the papillary type and the mentomonatus type. For the topographic chilasfication, there is many classification to classify the relation of the craniopharyngioma to the optic nerve and to the optic chiasm and to the supracellular cistern and so on. And there is no standard classification. Professor Yazargil in 1990 classified the craniopharyngioma into 6 types. Type A, purely intracellular intradiaphragmatic, like here. Type 2, intracellular with some supradiaphragmatic extension. Type 3 with a supradiaphragmatic extension with intra and extra ventricular extension. And type D or type 4 with intra and extra ventricular extension. And lastly, type E and type F. Type E is a paraventricular tumor in respect to the third ventricle, and type F is a pure intraventricular tumor. Okay, can you see the slides? Okay. Professor Sami and Professor Tadajiba in 1997 classified the craniopharyngioма into 5 groups. Group 1 is completely intracellular. Group 2 is a supracellular with or without intracellular extension. And group 3 involves the lower half of the third ventricle. Group 4 affects the upper half of the third ventricle. And the type 5 reaches to the septum pellucidum and they can extend to the lateral ventricle. After introduction of the endoscope, Dr. Kassam classified the the craniopharyngioma according to the relation of the origin to the infundibulum. There is a pre-infundibular, retroinfundibular, and transinfundibular, and completely isolated third ventricular craniopharyngioma. Also, another classification suggested by Dr. Pascual et al. For the supracellular tumor in relation to the third ventricle. Some tumor just push the intact floor of the third ventricle upward, and the type B with breaking through the floor of the third ventricle, and type C is a pure intraventricular mass. Most important is to know the relation between the craniopharyngioma and the optic nerve and the optic chiasm, and we can classify it is either prechiasmatic or retrochiasmatic according to the relation to the optic nerve and optic chiasm. Here, the normal relation between the optic nerve and optic chiasm. There are in the prechiasmatic craniopharyngioma, the tumor stretch the optic nerve so that the chiasm is pushed backward and superiorly, and that is a pseudo post-fixed chiasm. Like in this illustration, the tumor involves the angle between the two optic nerves, pushing the chiasm upward, stretching it, and is associated with long optic nerve, as we can see in the video, long optic nerve, stretched by the tumor, and that is carotid, and the tumor is prechiasmatic, and the chiasm is post-fixed or pseudo post-fixed with long optic nerve. In the other type is the retrochiasmatic craniopharyngioma. The craniopharyngioma pushing the chiasm anteriorly so that there is a short optic nerve, and the tumor is retrochiasmatic and can extend to the third ventricle or penetrate the third ventricular floor, or maybe completely third ventricular tumor, and that is, we call it a pseudo-prefixed chiasm. Like this video clip is a short optic nerve, the chiasm is pushed anteriorly, and that is a pseudo-prefixed chiasm. So that high resolution MRI should be performed, sagittal, coronal, and contrast cuts with FLAIR image to study the normal or the disturbed anatomy of the chiasm, whether the chiasm, whether it is a prechiasmatic or retrochiasmatic craniopharyngioma. For that, if we have a case like this, a prechiasmatic craniopharyngioma, we can use a approach transcranial from above or from below through endoscopic or endoscopic endolaser. If we have a classic microsurgical approach, we can use a classic terional or transsylvian approach and bilateral interhemispheric approach, or bilateral subfrontal, or supraorbital mini craniotomy, which is called a frontolateral approach. All come from below through the endoscopic route, but we must be sure that this is not a pure third ventricular craniopharyngioma. If we have a retrochiasmatic craniopharyngioma like this, you can approach it either also transcranially, microscopic, or endoscopic. For the transcranial, we can use also the terional approach or bifrontal approach or supraorbital mini craniotomy approach, but we must inside the stretched lamina terminalis to reach the tumor. In the past, Dr. Hakuba in 1997, they started to use a transfusal approach to reach the retrochiasmatic craniopharyngoma from behind. It's a very extensive surgery, can be complicated by facial palsy or cochlear injury. But the merit of this approach is to dissect the capsule from the perforator of the basilar artery and the P1 and P2 perforator. Also, if we have a third ventricular craniopharyngoma like this, you cannot use endoscopic intranasal approach because you can violate the floor of the third ventricle before you reach the target. So that's one of the absolute contraindication for endoscopic intranasal approach in the pure third ventricular craniopharyngoma. You can use the translaminal terminalis corridor either through the terminal approach, frontolateral approach, bifrontal approach, or to use a transcortical or transcallosal approach, either microscopic or endoscopic. However, endoscopic intranasal is contraindicated in this situation in cases of pure third ventricular craniopharyngoma. The endoscopic, now in endoscopic era, once it is indicated for a small midline tumor to be not pure third ventricular craniopharyngoma, has a merit of early recognition of the optic nerve and the optic chiasm, and also have a good chance to deal with the hypophyseal artery from below better than from above. But the problem is to deal with the A1 or A2 or ACOM complex if they are involved by the tumor, or if there is a paraventricular or paramidline extension. For each approach, and another case is next topic for the complex and recurrent cases of the craniopharyngoma, you can use bifrontal approach or terminal approach or mixed or staged surgery using one of them according to the situation or the topographic anatomy of the craniopharyngoma. Like this case, you cannot use a single approach, either staged surgery or to use one approach followed by a second one or in the same setting. Other modalities for the craniopharyngoma should be taken in mind, particularly if you have a cystic craniopharyngoma with multiple recurrence and so on. You can use an Omeyer reservoir for repeated aspiration and to inject some material like pleomycin. Also, we should consider the post-operative radiosurgery and the gamma knife, particularly if there is gross total or subtotal removal. Because in the literature, we found that gross radical removal may be associated by high morbidity and high mortality rate. But if there is a gross total removal or even subtotal removal with the chance for post-operative gamma knife, may improve the functional outcome. For the terminal approach, that is the classic picture of the terminal approach when you expose frontal lobe and the temporal lobe and open the sylvian fissure, drain the CSF. We can recognize the ipsilateral and the contralateral optic nerve and the carotid bifurcation that dissects the capsule from both optic nerve and the chiasm, and you can recognize the pituitary stalk. And if you extend your approach, you can expose the basilar artery and the basilar bifurcation and dissect the tumor capsule from basilar bifurcation and the P1. The terminal approach is indicated for the both pre-chiasmatic and the retrochiasmatic craniopharyngoma. For the pre-chiasmatic, particularly if there is para-midline extension or even midline extension, and also if there is recurrent cases as a stage of surgery, and also used in retrochiasmatic and third ventricular craniopharyngoma. Like in this case, a pre-chiasmatic craniopharyngoma with extension to the left side, the paramidline. You can open this case by classic left terminal approach, and after opening of the sylvian fissure, you can see here now microsurgical exposure and the dissection of the optic nerve. That's the left optic nerve, that's the right optic nerve. We start to remove the tumor from opticocarotid triangle, and then start to identify the contralateral optic nerve, that is the right optic nerve. We can dissect the capsule from the right optic nerve and follow back, and that's the right carotid. and follow the capsular dissection to be dissected from the optic chiasm and return back to dissect the ipsilateral optic nerve, like in this case, just to compress the capsule and start to dissect the capsule from the ipsilateral and the contralateral optic nerve. And then we start to compress the ipsilateral or the left optic nerve by removal of the tumor from its inferior surface. And that is the left carotid bifurcation. That is A1 on the left side. And the capsule involving the A1, involving the perforator. You can filtrate the capsule and start to drag or dissect the capsule from beneath the M1 and the A1 and deliver the remnant of the capsule. That's the right optic nerve, right carotid. Optic chiasm is now completely free. Part of the capsule is delivered from the ipsilateral optic nerve. The tumor is partially calcified. And now you can remove the tumor after being dissected. That's all the tumor was removed. And that is the right optic nerve, chiasm, left optic nerve, left carotid, carotid bifurcation, M1 and A1 in the view. Most important is to dissect the liquid membrane if there is any adherence. That is the end stage. This is the pituitary stalk. Now you can see the pituitary stalk. Part of the tumor remnant was adhered to the pituitary stalk here. You cannot move it totally because if you manipulate more manipulation or to cut the pituitary stalk to obtain a radical resection, it's not acceptable. Just if you have a small remnant, like this, follow up and the patient may receive gamma knife whenever it is needed. That is the end view of the terminal craniotomy. And this is the lamina terminalis stretched. That is the A1 complex. All of them are free of tumor. That's a preoperative MRI, and that's a postoperative MRI. Also, the terminal approach could be used in the prechiasmatic craniopharyngioma with the midline or paramidline extension, like this case. Stretched optic nerve, very long optic nerve. That's the carotid. That's the BCOM is very large in this case. We started to dissect the capsule and open the capsule, aspirate the fluid, start to debulk the content, either the solid part or the calcified part, and by the same technique, start to dissect both optic nerve and to dissect the tumor from right or to left optic nerve and follow the dissection back to the chiasm. The capsule is very thick and adherent. That's the right optic nerve, carotid bifurcation. Below the capsule, you can see the liquid membrane and the basilar artery and the basilar bifurcation. Here's the last piece of the tumor from beneath the chiasm. And now we can see well the left basilar artery, left P1, and that's the basilar artery here, the B1, SCA, and oculomotor nerve on the left side, no tumor. Also, you can follow the opticocarotid triangle and search for any extension or any cyst or any residual, and that is the oculomotor nerve. A part of the tumor is still present in the intracellular component. You can reach it and dissect and remove it. The perioperative MRI, the post-operative MRI. Also, the terminal approach could be used in the retrochiasmatic craniopharyngioma, particularly with some of calcification here in this boy. retrochiasmatic craniopharyngioma, you can use a classic trional by the same principle, frontotemporal craniotomy. The tumor is retrochiasmatic here. That's prefixed chiasm, short optic nerve, aspiration of the cyst through the lamina terminalis, opening of the lamina terminalis, start to debulk the tumor and dissect the capsule from the right side or ipsilateral side, then from the contralateral side. The tumor was partially calcified. Internal debulking, then dissection of the capsule. Internal more debulking of the tumor. Just to decompress, debulk the tumor, dissect the capsule from the floor of the third ventricle, from the lateral wall, ipsilateral, and the contralateral side. With the trional approach, the contralateral side may be so easy if compared with the ipsilateral. You can use the CUSA to debulk the tumor. Particularly for the calcified portion. And that's the basilar artery. Now we can see it. That's the floor of the third ventricle here. That's the pituitary stalk here. And this is the prefixed chiasm, and that is the opened lamina terminalis. That's the preoperative and that's the postoperative. Each approach has advantage and disadvantage. The disadvantage of the trional approach that the posterior or superior angle, particularly in the ipsilateral side, may be difficult to be controlled, so that you can combine the microscopic with the endoscopic assisted surgery, particularly for the blind angle. For the frontolateral approach, a small mini craniotomy approach, can use eyebrow incision. Also, you can increase your exposure by drilling the roof of the orbit, or to remove the orbital rim with the frontal craniotomy, or to use combined frontal craniotomy together with orbital osteotomy to remove the superior orbital rim together with the flap to obtain a mini craniotomy flap like this, and that could increase the basal exposure, particularly to deal with the ACOM complex. A case of retrochiasmatic craniopharyngioma like this, you can use the frontolateral approach, that is A1. Care should be taken during the dissection and during opening of the lamina terminalis. Just open the midline, internal debulking of the tumor by the same technique like the trional approach. Care should be taken to preserve the A1 during dissection of the tumor. The calcified part could be removed by CUSA also. And that's the chiasm. And also you can introduce 30 angle endoscope to dissect a remnant of the capsule and to examine the floor of the third ventricle and the lateral wall, particularly in the ipsilateral side. If there is any remnant around the basilar bifurcation, you can dissect it easily using the endoscopic assisted surgery. As the preoperative is the calcification, post-operative, perioperative MRI, and post-operative. Also, you can use a frontolateral approach for a prechiasmatic craniopharyngioma. If you have a larger tumor, you can use the same policy, small craniotomy, opening of the cyst, delivering of the cyst content, and dissect the capsule from ipsilateral and from the contralateral side. Has the same advantage with the trional, with a small incision and a small craniotomy. Can work in the optico-carotid triangle, deliver the capsule from the angle between optic nerve and the carotid, and between the two optic nerves. And that is a pituitary stalk, still intact in this case. That's the Lille-Quist membrane. The tumor is partially removed, and that is the basilar artery. And the end view, right left optic nerve, carotid bifurcation, and the pituitary stalk is preserved in this case. The patient, after 4 months, developed a small recurrence like this, and presented by a deterioration of the vision on the left side. And I reopened again after 4 months using a triennial approach. And it was a retrochiasmatic extension, not a prechiasmatic extension. So that after opening of the Sylvian fissure, that is the left optic nerve, I used the lamina terminalis approach, obviously the lamina terminalis, and remove a residual part of the tumor. And the patient received the gamma knife, but unfortunately, the vision was not improved. Another case, calcified retrochiasmatic craniopharyngioma. I used the frontolateral approach by the same technique, and that is a post-operative CT scan and post-operative MRI. The advantage of this approach is a minimally invasive approach, but it is suitable only for the smaller tumor occupying the midline. We can increase the exposure by using endoscopic assisted surgery. Anatomical preservation of the pituitary stalk, like in this case. Another case with dissection of the tumor from the pituitary stalk. The pituitary stalk is a remnant of the tumor around it. Another case, and is a remnant of the tumor around the pituitary stalk here. And that's a retrochiasmatic craniopharyngioma with intact pituitary stalk. Pituitary stalk preservation was present in 30% of my cases, but all of them developed transient DI. Hormonal replacement was given up to 66% of my cases. Most important is to preserve the perforator from the carotids and from ECA, particularly perforator to the optic chiasm. During opening of the lamina terminalis, you should open it in the midline in the most stretched part. Also, care should be done to preserve the perforator from the basilar artery. And to dissect and do compress the oculomotor nerve. From 35 cases were operated on, gross total removal was achieved in 68%. Subtotal removal with post-operative gamma knife in 31%. Mortality for cases, 11.4%. Pituitary stalk was preserved only in 30% of the cases. Hormonal replacement was given to 66% of the cases. And recurrence, I have for 5 cases recur after that, and redo was performed. In conclusion, many approaches are described, and each approach has advantage and disadvantage. Nothing is said absolute indication or absolute contraindication. Radical resection is associated with morbidity and mortality. Gross total removal is the best whenever it is possible, and gamma knife for the residual should be taken in mind. Recurrence rate is high. However, we must follow a policy of do no harm, because post-operative quality of life should be considered. And thank you very much all for your attention. Thank you.
I'd like to thank Professor Khalid El-Bahi very much for this great talk. And now we are going, I think we are going to make questions at the end of this session. We have 20 minutes for discussion. For all participants, please write your questions. And now I have the pleasure to introduce my friend and my brother, Professor Dr. Jenkins Alistar. We are honored that you are contributing to this session. He is going to speak about different approaches in the management of craniopharyngiomas.
Thank you very much indeed. And I'm sorry to say that it's going to be a very similar talk. Because you've stolen my slides. You've told exactly what I was going to say. It's interesting how much we feel the same about this very, very difficult tumor. And I even started my my talk in the same way as you. It's worth just highlighting one or two things from here. As well as occurring anywhere from the pharynx to the third ventricle, they can actually be elsewhere, even the CP angle. I'll show one at the end where it's reached there, although it didn't originate from there. I have seen one that's metastatic in the frontal lobe, which is very strange. It didn't seem to be histologically aggressive. And we wonder why, if these tumors are from remnants of the craniopharyngeal duct, why do they have this bimodal growth pattern? Why do they suddenly give a second peak of growth? And I don't think the picture of the development really helps us very much in that. We can obviously understand why you would have a childhood tumor, and I think they truly are congenital, but whether the adult ones are, we really don't know. And as has been said, there are two age peaks. They're commoner in children as a percentage of tumors than they are in adults. And the two different kinds, although they can be mixed. And I think the most important thing is that as time goes on, you have less of a chance to remove these completely because you get fibrosis, you have inflammation, and the vessels and the nerves around these tumors get stuck. And that's part of the reason why, as I'm going to be highlighting, you maybe only get one chance to remove these tumors completely. We've seen these slides before. It's surprisingly rare for them to be purely cellular, and they are mostly supracellular or both, which obviously means that they are often presenting such that the pituitary gland is below the tumor, and that obviously makes life difficult from the point of view of surgical approaches because it makes the pituitary stalk very much at risk. They present in various ways. The adults usually present with visual disturbance. I've got one who's due for surgery next Tuesday who presented during the week with a cystic craniopharyngioma. She's 60 years old and she has no other symptoms at all. Children more often develop endocrine dysfunction, and very often you get growth failure or premature puberty or obesity. And diabetes insipidus is relatively rare, although I had a patient recently who presented primarily with diabetes insipidus. And very rarely, of course, you get raised intracranial pressure, particularly when they're in the third ventricle and cause hydrocephalus. And of course, everything can be used for treatment of these. And I think I've tried every possible surgical approach apart from the lovely one we saw earlier on from behind, which I wouldn't really fancy doing. But I think nowadays we are looking more and more to involving other disciplines in our treatment. Intracavitary radiation was a big thing a while back, but now we're thinking of intracavity chemotherapy as an adjunctive treatment. And of course, the big problem is that this is right in the very center of the brain. It's right in the center of the head, and there are all these other very important structures around, all of which are at risk. And this is our stamping ground. This is middle base of skull surgery with all the problems that it entails. But although it can look hopelessly complicated sometimes, I remember Axel Pernetsky telling me that if you can see light through the trees, and I'll show you that picture in a moment, then you can always get something out through that hole. And these are some of the different approaches which have been highlighted so far. To look at the pterional craniotomy first, all these structures are accessible through it, but of course it also means that all these structures may be in your way and may be at risk from your surgical approach. And particularly at risk are the optic nerves, the third nerves, and the many of the arteries. This is a model just showing obviously the area involved, and there are some advantages to this approach. I think the main one is that it's familiar. It's also the shortest distance from the outside to the inside, and that has many advantages because of less retraction and less potential disruption of the brain. This is one of the first approaches that we learn when we're training, and we know that area like the back of our hand, and so we can see if there's anything that's not where it should be and hopefully try to preserve it. The disadvantages are, I think the main one is that it's a unilateral approach for a midline or bilateral tumor. And we have seen that all the vessels, the optic nerves, the third nerves, are between you and the tumor. And so you have very small access windows between these important structures. I think one of the biggest disadvantages is that it's only really useful for quite small tumors that are not going up into the third ventricle, because although often you can pull a tumor down, you cannot always do that. And you may end up with a situation where you've got half a tumor out and the bulk of the tumor, or 50% of it at least, is still up in the third ventricle. Also, because you're going flat along the base of the skull, if the sella is enlarged and the tumor is poking down into that, your access, your view of the sella may not be very good. This is the classic view we saw earlier of the basilar artery in the distance, the third nerve, I can't get a pointer up here for some reason, and the ipsilateral optic nerve, pituitary stalk, the carotid bifurcation. And the windows that we're using, you can see there in between. But it is useful for some tumors. This sort of solid craniopharyngioma here, it's mostly solid, a little bit of a cyst. This is ideal for this approach. It's not going down much into the sella. It's not going up into the third ventricle. The optic nerves are nicely perched above it, and so there's minimal disruption of that. And that's a post-op view of that, which you'd expect. This is about as large or extensive as I would want to approach from the pterional view. This is in fact the young chap who presented with diabetes insipidus. As you will see, he's also not the shape he should be. He's got obesity. On top of that, he had been misdiagnosed and he'd been made Cushingoid. So he was a bit of a challenge. But we did manage to get all that out through that approach. Very fortunately, he had very good tissue planes and we were able to get that out. So recommendations for this approach. I think the most important thing is to do a very low craniotomy. I'm not a fan of the orbitozygomatic craniotomy because I think that if you cut your ordinary pterional craniotomy as low as you possibly can and use lumbar drainage and split the sylvian fissure widely, you can get very low on the skull without doing extra bone work. And you have to be prepared to move the microscope around a lot, to use all the different windows that are available between the chiasm, between the optic nerve and the carotid, behind the carotid, between it and the third nerve, and even if there are no perforators, above the bifurcation, and often even under the temporal lobe or in front of the temporal lobe. And the pterional is such a versatile approach. You can get a lot of these windows very easily. But be aware that retraction is a problem and that the small feeding vessels to the optic nerves, as we spoke about earlier on, are a problem. And this is the picture of the trees with the light coming through. If the light comes through, you can get through as well. So to move to what is actually probably the approach I've used most over the years, for some reason we seem to deal with a lot of large tumors, and they're out of the scope, I think, of the pterional approach. The mid-frontal interhemispheric has a number of advantages. It's philosophically very easy. There's not an awful lot between you and the tumor in terms of important structures, so it's easy access. Once you're there, you get a very good view of the anterior cerebral arteries, the anterior communicating artery, both carotids, Once you're through the back, you see the basilar artery. And of course, the main thing is the ability to see and preserve the chiasm, both optic nerves, both optic tracts. The third nerves are well out of the way usually with this, so they're less at risk. And the pituitary stalk is more likely to be readily identified, I think, through this approach. If the tumor is going up into the third ventricle, especially if the chiasm is prefixed, as was said before, then you can get through the lamina terminalis. But even when it's slightly postfixed or over the front of the tumor, you can still get through the lamina terminalis to perform the last bit of the operation. The other good thing about this is that it's easy to combine with some of the other approaches, and I'll talk about that right at the end. And here's the model again, with 2 optic nerves, 2 carotid arteries, the postcom artery, posterior cerebros, and the pituitary stalk in the middle. And again, looking from the top, this is really to remind me that I remember coming in on one of my trainees doing this approach once, and he'd taken off a bar around the orbit, taken off an orbital bar. I said, "What are you doing that for?" "Oh, I need to be very low, I need to be very low." You actually don't need to be low in this craniotomy at all. And I would always do it so that it's above the frontal sinuses, so that there's no risk of persistent CSF leak, meningitis, etc. In fact, you want to be relatively high because you want to be able to see down into the pituitary fossa. And the advantages to doing a low craniotomy in this, I think, are outweighed by the disadvantages. The problems with this approach are the frontal sinuses, but that's not a major thing. And especially if you are using image guidance, which I must say I don't, then you can keep out of the way of those. One of the problems is that the 2 frontal lobes can be quite adherent to each other with PL adhesions and can be a little bit difficult to prise apart. I tend to use Surgicel and a patty just to peel them gently apart. It is a fairly deep access, as I'll show you in a moment, but then we're used to that. That's what we do in neurosurgery. The olfactory nerves are at risk. You just have to be aware of that, although often they will be pushed to one side. And you have to take care with the optic nerves and the chiasm, but you do get a very, very good view of them. This is the beginning of such an operation. You can see the edge of the cella at the front and a large mixed tumor here. And as we progress, taking the tumor out, and then at the end, you can see the pituitary stalk. You can see the left optic nerve, just the edge of it there. You can see the brainstem at the back. And it's a very nice, anatomical, easy to understand approach. And it's very difficult to get disorientated, which is quite important. And it can be used for cystic, it can be used for solid tumors. This is a large cystic tumor in the child, really pretty much everywhere. But again, it's giving us a way into it. So we can get into that cyst and take the whole thing out. And this child is now an adult. That was him at 10 years post-op with no recurrence at all. Solid craniopharyngiomas, again here, this is a very prefixed chiasm, as you can see. So through the lamina terminalis, we can get that out without too much problem. This is actually someone who works in our hospital. He's about 10 years out from surgery too, and he's had no recurrence. I get a nice card from him every year to remind me. Most craniopharyngiomas are mixed, and sometimes that can be a great help, as we saw in the first presentation. The cyst can help you to take out the solid tumor, and you can reduce the bulk of it very easily. This is another one that's really made for this anterior interhemispheric approach. And this girl, again, is many years out from surgery. What she's got, however, is hypothalamic obesity, and she does have some visual field cut, but she's perfectly functional from that point of view. Another mixed craniopharyngioma, and this one I'll go back to later on, because you can see that although the bulk of this tumor is quite posterior, there is a bit going out anteriorly there, and you can see the optic chiasm suspended in the middle. And that is a good one to go from the front for as well. And that's the post-op picture there. So tips for this approach, I think mark out the frontal sinuses, either just by measurement or by using image guidance. make the craniotomy above them, unless there's a very good reason not to. I don't cut the falx, I just go down the right side between the right hemisphere, right frontal lobe and the falx. As with every approach, watch out for the vessels which are feeding the optic nerves and try to protect them if possible. I learned this, I have to say, relatively late on. It took me a few years to work out what the basis was of visual preservation for these tumors. But now that I've got that, it's been a while since I had someone with a serious visual problem afterwards. If a tumor up into the third ventricle doesn't mobilize easily, it's best not to pull it down, and you're best probably to open the lamina terminalis, but be aware that the optic tracts are a little more vulnerable than the optic nerves to traction. As we saw in the very elegant videos in the first presentation, you can actually retract the optic nerves quite a lot, and indeed it's very often necessary to do so. The optic tracts, I would say, rather less so. Another of my favorite approaches, transcallosal. The advantage of this is it's actually extremely easy. And in spite of all the literature there was around the 50s about disconnection syndromes, I've found that it's actually very well tolerated. And I've yet to have any patient who I've done a transcallosal approach for any tumor who has got any deficit which you would attribute to the fact that you've gone through the corpus callosum, which of course is an enormous surprise because you think it must be there for some reason, but I have not managed to find any problems yet. And the advantage is that it gives you a very wide aspect to high tumors. And as we saw in a previous slide there, many of these tumors presenting quite high up are partly cystic. And so if you go through the corpus callosum, before you know it, you have a very, very large approach to the solid part of the tumor. And this is just obviously to show that it's quite deep as well. The corpus callosum is easily recognizable, and you just have to protect the anterior cerebral arteries. I usually put the retractors actually over them in order to protect them. Disadvantages, well, the arteries are at risk. Again, I haven't actually had a problem with that. I think one of the most important problems is that the basal structures, and you're often go down onto the posterior cerebral arteries, the basilar bifurcation, some of the perforating arteries around there, and indeed the pituitary stalk, they're often not seen until quite late in the procedure by definition. You've also got to be quite careful about hypothalamic damage. Peeling this tumor off the hypothalamus can be dangerous and has to be done quite carefully, or using the CUSA to get down just to the level of the hypothalamus, but no further. And you have to be very careful of the fornices. You can resect or dissect behind the fornix, but dissecting in front of it is potentially a big problem. But these are large and difficult tumors, and you wouldn't be doing this approach unless they were. It doesn't mean you have to accept the collateral damage, but you have to be aware that there's always a balance between resection and potential neurological problems. So this is the kind of tumor that I would tend to use a transcallosal approach for, presenting well up into the third ventricle. And I'll show you the landmark I use for that in a moment. You can see there's a very prefixed optic chiasm there too. Oops, sorry. And that's a post-op view of the same patient. You can see the optic chiasm very nicely outlined on that left-hand picture. And you can see here the sort of 2 centimeter anterior callosotomy that's used to get in there. So tips for this, it's quite strange that for a craniotomy that is going front to back, people very often use an incision that goes from side to side. I use a linear incision straight along, more or less from the hairline, 2/3 in front of the coronal suture, 1/3 behind, and make a similar craniotomy. A long, thin craniotomy is good because it will allow you to select an approach that spares the bridging veins. Once in a while, you actually have to operate on either side of a bridging vein, if it's a large one. I do try not to take them if possible, because even obeying the rule that you can take anything in front of the coronal suture, it's not always true, I'm afraid to say. And I have had one case of venous infarction, fortunately, with a good outcome from taking a large bridging vein in front of the coronal suture. It's quite easy to get lost with this approach, and there are some very easy ways to ensure the correct trajectory, even if you don't use image guidance. And one of the ones that I use is to take an ECG connection dot and simply put it onto the zygoma in the correct orientation. It's usually about 2 centimeters in front of the tragus, 2 to 2.5 centimeters. And if you use that, and I even do a simple thing like standing beside the patient, looking at the orientation of the microscope and seeing that it's in line. And I teach the juniors not to be embarrassed by doing that, because it's a very sensible thing to do. Again, got to be careful with the fornices. And the difficult area is anterior, because you're coming down in between the optic tracts, and it's quite difficult to get underneath the optic chiasm to get the anterior part of the tumor out, because you don't want to be having a trajectory that goes from too far back in the head, because then you have worries about the bridging veins. How do you choose which to use? The way I do it is to look at the dorsum sellae. And if the bulk of the tumor is behind the dorsum sellae and it's going into the third ventricle, I think it's a good idea to go transcallosally. If, as in the tumor on the right, an awful lot of the tumor is in front of the dorsum sellae, even though the tumor is going high up, I would favor an anterior and hemispheric approach. And as I said earlier on, we go back to this patient. This patient's tumor is looking like it should have a transcallosal approach, but in fact, because of that anterior extension, because of that thing I said earlier on about being able to work from within a cyst, I went anterior and hemispheric for that one. So view of Scotland last year. Now, endoscopic, obviously very fashionable and very, very good. It gives you very good access to cellar tumors or tumors going down into the cellar. I think one of perhaps the falsehoods that's attached to this is that it avoids a craniotomy. A basal craniotomy is a craniotomy. It may not have the reported incidence of epilepsy that allegedly pertains to other craniotomies, but in fact, epilepsy is very rare, and it's a craniotomy that is very difficult to seal. It gives you limited access for larger tumors, and you're often having to peel a tumor or a tumor cyst off structures that you can't really see, and so you're relying a bit on faith that you don't pull something you don't want. The pituitary gland is usually between you and the tumor, and as we've said before, many craniopharyngiomas are adherent to their surroundings, and so it gives you a relatively poor ability to remove it from there. And of course, the eternal problem of CSF leak. And here we can see a classic example of a small craniopharyngioma, which you'd love to go transsphenoidally, but there's a large pituitary gland there, which is telling you that it may not be such a good idea. And there are plenty of people who would go for that transsphenoidally. They'd go above the pituitary, they'd mobilize it downwards. But personally, I think it'd be just as easy to do a small pterygium craniotomy for that one, which is indeed what I did. This one, on the other hand, is crying out for an anterior, for an inferior approach, for an endoscopic approach. And that indeed is what we did. You can see there's quite a large solid bit going towards the third ventricle. But in fact, that came out very nicely because once again, we've got a cyst to work through. That was only done a few weeks ago, so we don't have a post-operative picture. So that's my sort of roundup of the resective procedures. There are, of course, cyst drainage procedures that can be done in older people. Sometimes that may be all you need. I wouldn't encourage that in young people if it's avoidable, and I will show you a picture of that. And then, of course, there's radiotherapy, or more particularly radiosurgery, which I think is increasingly being used as a method of reducing the need to do a supraradical resection. There is something to be said for cystoventriculostomy, which is relatively elegant procedure where you put a large cyst. I'm afraid I couldn't find a pre-op MRI because it had been done at another hospital, but you can see our CT planning picture there on the left. And you can see that there's a tube going into that cyst, and it has side holes cut into it in the cyst end and then in the ventricle end. So the tumor can chronically decompress itself into the tube, up into the ventricle, and with small doses of cyst fluid, it doesn't cause any problems, and that can be very helpful. I said I would mention combination approaches. The interhemispheric approach is very good because you can mix it. If you just cut it a little lower on one side, you can mix it with a subfrontal or transsylvian approach. Transsphenoidal may be quite useful. You get as far as you can with the transsphenoidal approach, and then you've managed to get a tumor which has fallen down from the third ventricle, and even if it's stuck to the surroundings and you can't get it transsphenoidally, you could then get it terionially. And once in a while, I've had to combine this for very large and extensive tumors with a retromastoid approach. Mortality and morbidity, this is well known. The 5-year survival is good because it's a benign tumor, but there is considerable potential for visual and endocrine and hypothalamic problems. The recurrence rate in international studies, if it's a big tumor, you've got a much higher chance of recurrence than you have with a much smaller tumor. Just to look at a couple of cases, this is a young girl who came to me, and the parents were rather resistant to any major surgery. So what we did in her case was to put in a cystoventriculostomy, and you can see the catheter there going into the cyst, and it's decompressed it extremely nicely. However, it then started to, and you can see the catheter there, it then started to recur, but it recurred in a solid way, and it's presenting nicely down into the sphenoid sinus, and so we did a transsphenoidal removal of this. And that went okay, but then you can see it's just beginning to recur a little bit, the solid bit there. And then, of course, again, we've got a cystic recurrence as well as solid. So I said to the parents, look, we're not getting anywhere with this. We've got to be a little bit more aggressive, but I think we may not be able to do anything major. Let's now just go in and fenestrate this cyst into the basal cisterns or into the sylvian fissure. But in fact, when I went in, I found that the tumor was perfectly easy to mobilize through the terionial approach, and the whole thing came out. And she's tumor-free as far as we can tell at the moment. So sometimes your first impression as to what you should do might actually be the best. A much less happy case, this is a chap I inherited. This is the first scan I have in 2002, but he was actually operated on in the early 90s by a colleague of mine. And by this time he had a tumor which was growing on the base of the skull, indenting the brainstem, and then this got much worse. So we did a transsphenoidal approach for this, got a bit better. You can see it's out of the brainstem, and he was fine. He's been extremely well throughout this. Then it recurred, did the same thing again. We did the same again, and we're beginning to think this may not work very well. However, it stayed okay for a while, then it started to get bigger, and by now it's spreading all over the base of the skull. For this recurrence in the brainstem, we did a cystoventriculostomy. You can again see the tube going in there. It's worked very nicely. But after that, he just had an inexorable increase in the size of the tumor, occupying the bone, going round into the base of the skull, and then finally going and compressing the brainstem. We went in through a retromastoid approach and removed a huge amount of this, but it had come back to the same level, and this is after that approach, and in fact a rescan only a few months later, and at this point we really had to give up, and sadly he died last year, probably 20 odd years after presentation. And so with him, it just makes me realize this is a benign tumor, but it may in the end have devastating consequences. You may contribute to those consequences if you're too radical, but equally, if you are not radical enough, you could end up with a patient who has a tumor that could have been excised completely, but who is condemned to lifelong operations because of recurrences. Every case must be looked at individually. I've heard people not that long ago saying that the approach for a craniopharyngioma is this: always do it this way. There is no right approach. And that was what was so nice hearing with the first talk. I completely agree. You have to be aware of all the different approaches and you have to be able to do them all. And never, ever do something because it's the only thing that you know. As I said, radical surgery is usually worth it where it is possible and where it is safe. Children are often easier than adults because the tumors tend to be less adherent. But the most important thing is don't give up, because these patients will have a long life if you just keep working on them. So just to say thank you very much to you in Egypt for asking me from this long way to talk with you. It's very nice to be with you again.
Thank you, Professor Jenkins. It's really a great talk. We are honored to hear from you about one of the most important subjects and specialties in neurosurgery, which is craniopharyngiomas. We have many questions, and as I said before, we will make questions at the end of this session. And now we proceed to our next topic from Professor Khalid El-Bahi. He's going to speak about recurrent and complex craniopharyngiomas, operative nuances.
Okay, Dr. Nasser, can you hear me?
Yes, yes, it's very good.
Okay. First, I'd like to express my great thanks and appreciation to Dr. Jenkinson for his elegant lecture today. And Professor mentioned many important facts about the recurrence, about the giant craniopharyngioma, particularly that affected the lateral and the third ventricle, and how it is difficult to preserve the fornices, these cases, and particularly for the bifrontal approach, how you preserve the anterocerebral artery complex, because there is adhesion or pale adhesion between the right and the left frontal lobe, and this may affect your dissection during the exposure, particularly in the interhemispheric approach. We skip some lecture videos. Most important, as I mentioned.
Khalid, did you share your screen already or no?
I share it.
No, we can't. We can see.
Okay, 1 minute.
Yes, now we can see. It's very clear.
Can you see it?
Yes, yes, it's very good.
Okay. Is it okay? Okay.
Yes, that's okay.
So that I mentioned before in the first lecture, a high quality MRI, sagittal and coronal with FLAIR image should be performed to identify the relation of the complex craniopharyngioma to the optic chiasm and the optic nerve and the basilar artery. As we mentioned before, no standard topographic classification was found till now. And for the cranio or the complex or recurrent craniopharyngioma, we can use either bifrontal craniotomy, terminal craniotomy, stage surgery, combined approaches, transcallosal, Omayer reservoir, and as mentioned by Professor Jenkinson, don't give up. You must work and you must follow up your patient, and any recurrence, you must follow your patient and deal with the recurrent cases. It was found that the recurrence rate of the craniopharyngioma is very high, up to 40% of cases in the long-term follow-up show recurrence. And it was found that supracellular tumor with infradiaphragmatic component was found to be associated with high rate of recurrence, and with subtotal removal without adjuvant therapy or chemo or radiotherapy or radiosurgery, also associated with high risk of recurrence. So that with a large complex tumor or recurrent complex tumors, you must be put your mind that you must not to be aggressive, and you must preserve the patient life, and you must follow the rule that do no harm, particularly for the functional outcome. Because most cases of the complex or recurrent craniopharyngioma, you cannot identify the pituitary stalk easily. For example, for the bifrontal craniotomy, either anterior interhemispheric or bilateral subfrontal approach for the complex craniopharyngioma, as mentioned by Professor in the last lecture, it may be difficult to dissect the anterior cerebral artery on both sides because there is marked pale adhesion. And also the disadvantage of this approach is the violation of the frontal sinus may affect the olfaction, but you can get large exposure to deal with the large complex tumor that affected both optic nerve and the ACA complex. Like this case, a child with a multi-cystic craniopharyngioma, compressing the brainstem, compressing and affecting the basilar artery here, so that you can use a terminal approach from one side, right or left, but better for this because it has a supracellular and the retrocellular and the retrochiasmatic extension is the best for it to perform a bifrontal approach. For this case, a bifrontal craniotomy, we can follow anterior interhemispheric dissection. You must search at first where is the optic nerve, the right optic nerve. That's a blood vessel, and that is the right optic nerve. Start to identify the right or left optic nerve. Start to debulk the tumor. Don't use spatula. Better to retract by the suction tip. Once you remove the cyst, you can find another cyst and another cyst, so that the multicystic craniopharyngioma may be adherent to the other cranial nerve, that's the optic nerve, is dissected thoroughly. And once you open the cyst, you can find another cyst and start to identify the Leydig membrane to know where is the underlying basilar artery and the perforator. Start another cyst to remove it, the bulk, and then start to dissect its wall. From the whole structure, you find it. Don't tract, just the bulk and dissect the capsule. Now we can see the basilar artery and B1 here after removal of this tumor. That is dorsum celli. There is a part of the tumor anterior to the dorsum celli, and that's the basilar artery. That is the right optic nerve. You can follow the basilar artery backward. You can see the oculomotor nerve on the right side, SCCA. You can see the left oculomotor nerve. There is a part of the tumor still above the basilar bifurcation. That's the basilar bifurcation, SCCA and BCA on both sides, and oculomotor nerve, but there is still remnant of the tumor. You can dissect it. Sometimes you may have a problem that you cannot reach what's beyond the basilar bifurcation, and you can use the endoscope as endoscopic assisted surgery, and I will show it in another case. That's a post-operative MRI. Still, there is a residual in the infradiaphragmatic portion. That's the post-operative MRI. Another case, this child received a radiotherapy and VP shunt with partial resection, and there is a large residual. Here we can see the shunt tube in the right frontal horn. That's the MRI of this patient. Large tumor extended from the chiasm to the retrocellular area, and the retrochiasmatic area penetrate the third ventricular wall and reach to elevate the corpus callosum. So that's very difficult to use it in single approach. You must decide whether you will start a bifrontal craniotomy or transcallosal, or to take both the interhemispheric and the transcallosal in the same session. That's a large frontal craniotomy was performed. So be stand by to explore or to open the corpus callosum after anterior interhemispheric dissection. The patient received a radiotherapy, so that most of cases which received either radiotherapy or gamma knife or 3D radiation therapy, the capsule of the cystic part is very, very thick. Like this case, we can see. After you open the cyst wall, you deliver the oily material. The capsule is very firm from the previous irradiation. There is adhesion to the optic nerve. Start to dissect optic nerve on one side, then follow it backward to the other side. Also, I don't prefer to use a permanent spatula or retraction, just you retract by your suction tape and start to cut the wall. The wall of the cyst is very tough. This from the previous radiotherapy and the previous surgery. And after dissection of the capsule and delivery of the content, we can now decompress the oculomotor nerve and the basilar artery. That's the basilar artery, basilar bifurcation. And there is a large tumor behind the basilar bifurcation, elevating the floor of the third ventricle and reach up to the lateral ventricle and the corpus callosum. In the same setting, I performed callosotomy with preservation of the pericallosal artery, as we see here, and start a transcallosal corridor to compress the tumor. And you can use the CUSA of this tumor, and you put external drain after decompression of the lateral ventricular compartment, so that you can use a bifrontal craniotomy in this one setting and transcallosal. That's the floor. This is the fornices here. And you can use a staged surgery according to your time schedule and the anesthetic consultation during the surgery. That's the post-operative CT scan. The shunt tube is present, still present in the frontal horn. I lift it. And that's the follow-up MRI. Still there is residual in the infradiaphragmatic portion for the follow-up. Another case, also a complex craniopharyngioma, operated upon another center, and that's the encephalomalacia after the previous surgery. That's the CT scan and MRI T2. There is a pseudocyst or encephalomalacia after previous surgery. Both carotids were involved in this case. So that I performed the same technique, bifrontal craniotomy, and started to dissect the dura from the previous encephalomalacia in the right side first. And that is a solid part of the tumor by the symbology. Internal debulking at first, then try to dissect the capsule from the optics and from the carotids. Most important was the dissection of the capsule after being debulked from the carotid on both sides. Start on the right side at first after internal debulking. Can use also CUSA in these cases. There is a partial calcification. After debulking, that is the internal carotid artery, that's the carotid bifurcation. You can follow the A1 along the arachnoid, that is the A1, long and stretched, and follow the right side to the ACOM complex to the left side, and the retrograde dissection toward the diaphragm head. That is the A1 on the right side. This is a very important anatomical landmark, just to compress the tumor, dissect the capsule from the right carotid and the right ECA, follow the ECA A1 or A2 to the ACOM complex, and the retrograde dissection to the contralateral side. and you must follow the arachnoid line of cleavage. There's marked adhesion around the ACA complex in this case. Another piece is removed by the same technique. Internal debulking, capsular dissection along the anterior cerebral artery with preservation of the perforator from the ECA as much as possible. This arachnoid dissection around the capsule here, try to preserve the arachnoid as much as possible. Very tough because of previous surgery and so on, and the previous irradiation. This is a preoperative CT scan, post-operative, still there is a remnant. Also another complex cases, 3 or 4 previous surgery, previous irradiation for this child with extension to the nasal cavity. Ommaya reservoir to Ommaya reservoir, we can see the Ommaya reservoir here. Previous surgery, previous irradiation to Ommaya reservoir, a very tough surgery. Also, interhemispheric dissection as usual. Start to debulk the calcified part of the tumor. It's very tough and calcified. Can use also CUSA intracapsular. The bony part of the within the capsule of the tumor. It's just a calcification like a bone. Can remove it and debulk it. And most important is dissection around the carotid artery, or at least the ECE, because you can injure the ECE either in the right or the left side. This is the basal part and the left for the transsphenoidal surgery. Now I can dissect the tumor from the ECE on the right side, marked adhesion from previous surgery and from previous irradiation. Part is very adherent and ossified, not calcified. Still there is a remnant around the ECA complex. Try to remove it in all direction with preservation of the artery as much as possible. And that is the Ommaya reservoir. 2 Ommaya reservoir were present because it was a cystic once a day, then changes the character from the cyst to be solid. The capsule of the tumor was removed, and then now we started to debulk the tumor around the Ommaya reservoir. More follow-up, and that's the Ommaya reservoir. Another case with the calcified craniopharyngioma within the third ventricle. Can use bifrontal approach, you can use terional approach, and you must open the lamina terminalis in this case. In this case, you can see there is a redundant anterior cerebral artery on the capsule of the tumor. As mentioned before in the past with Professor Jenkins, that is very difficult for the interhemispheric dissection is to preserve the A2 and ACOM complex. Like in this case, you can find a redundant anterior cerebral artery above the capsule of the tumor. And start the interhemispheric dissection. Sorry. Interhemispheric dissection, there is adhesion, and you know, there is a short optic nerve and the prefixed chiasm. The dissection is very difficult, particularly for the retrochiasmatic craniopharyngioma. That is the chiasm. That's the 2 anterior cerebral artery here, as seen in the MRI. That is the A complex. That is the lamina terminalis is stretched by the tumor. Start to open it in the midline and start to debulk the tumor and to dissect the tumor capsule from the floor of the third ventricle and the right and the left lateral wall. In the terional approach, you can dissect the capsule from the contralateral side very, very well, but from the ipsilateral may be difficult. But in the bifrontal approach, you can see right and the left side. You can see the floor. This is a calcified portion of the tumor. I can use the CUSA to debulk the calcified part. The chiasm is pushed anterior. At the end, you can put your endoscope and to search for any residual around the basilar artery. There's a part of the tumor still present at the bifurcation of the basilar artery, and you can manipulate it endoscopically. It's better because the microscope, whatever you change the angle of your work, you cannot reach the posterior superior part. And that's a post-operative CT scan. And that is a redundant anterior cerebral artery, which was preserved during the dissection, as mentioned before. This anterior cerebral artery at the end of surgery. The preoperative and the post-operative MRI. Also, you can use a terional approach for the large and the giant and complex craniopharyngioma, either a single approach or combined with other approaches in the same setting or as a staged surgery. This is a small craniopharyngioma. The patient was deteriorating after 3 months after gamma knife surgery. The patient refused the surgery at first and received the gamma knife, and then came to me with bitemporal hemianopsia and the visual deterioration. In this case, we can see I started the classic terional approach. That is the right optic nerve. Started to identify where is the right, where is the left optic nerve. I started to work in the space between right and the left optic nerve, like this. Cyst evacuation is very, very firm, not calcified, but very firm because the previous gamma knife. We start to debulk the tumor in the angle between the two optic nerves, and the capsule was adherent to the chiasmatic or to the optic chiasm itself, that it was intercellular between the two optic nerves, then jumping above and was adherent to the chiasm. So that dissection around the chiasm should be very meticulous to avoid injury of the perforator to the chiasm, because injury of the perforator to the chiasm may lead to spasm and hypoxia or ischemia of the hypothalamus. We start to dissect the capsule from the right optic nerve here. That's the chiasm now, but still above the chiasm, there is part of the tumor is still adherent to the left optic nerve here. There's the right optic nerve, left optic nerve, and a firm part was dissected from the chiasm. Dissection of the solid part from above the chiasm, still adherent to the chiasm. Is the lamina terminalis stretched, but there is no tumor within it. A residual is very firm, still adherent to the left optic nerve. The adhesion of the part of the tumor to the chiasm. If there is bleeding from the venous bleeding, try to compress it. The residual part of the tumor was dissected from the chiasm, and now I try to remove it by the CUSA, but it is very, very firm. Now the last piece was removed. And that's the right optic nerve, left optic nerve. The chiasm is free. And still part within the tumor within the cella, and they bulk it after that. Be sure that there is no tumor in the opticocarotid triangle on both sides, and that now the chiasm is free, and the lamina terminalis is pulsating here. That's a preoperative MRI and the postoperative. There is still small residual within the cella or infradiaphragmatic portion. Another case of prechiasmatic craniopharyngioma operated twice, and also it was cystic, and after gamma knife and Omeya reservoir was applied for repeated puncture, but still is a patient complaining from visual affection. And started by a udesiternal approach, market adhesion. This is a cyst was aspirated. The cyst wall is very thick. It's not a virgin case. Was mini surgery. That's a carotid bifurcation. As the recurrent artery of Rubner was dissected from the tumor on the right side. You should preserve the A1 and every perforator from the A1. Even there is some bridging arteries supplying the capsule of the tumor. That's the right optic nerve here. The cyst was evacuated, but the cyst content is very firm. If you aspirate only, the recurrent rate will be high, and it's better to remove the solid part after aspiration of the cystic part, and start to debulk and dissect the capsule from both optic nerve and from the chiasm with preservation of the feeders or perforators from the ACA complex. Also, take care from the any penetration of the posterior aspect of the capsule. You can injure a perforator from the basilar artery. That's a CSF from the iliac membrane. Now we are approaching the basilar artery. You must take care not to injure any perforator from the basilar artery after opening of the iliac membrane. Here the tumor capsule is dissected. You can open the capsule, you find another cyst behind it. That is the basilar artery shadow. The brainstem is decompressed now, but there is still residual within the or infradiaphragmatic component. Most cases of recurrence is the residual infradiaphragmatic part because you cannot remove it transcranially. And that is the basilar artery, that is the liquid membrane was opened, brainstem was decompressed. And still there is a capsular remnant around the optic nerve, start to dissect it. And you can work in the angle between the carotid and the optic nerve, and you see the superior cerebellar artery and the P1 on the right side here. Is the angle of opticocarotid triangle. And that is the basilar artery was intact. Still, that's the preoperative MRI, and that's the postoperative MRI is still residual within the below the diaphragm cell for follow-up or for transsphenoidal surgery after that. Another case, recurrent craniopharyngioma, operated 2 times before, received gamma knife. Still, there is a residual, but now in this case, the residual is calcified. That is the right optic nerve. Now I am working in the opticocarotid triangle. Decompress the basilar artery. There is a basilar artery, and that is the A1. Instead, there is a residual between the carotid bifurcation here. The tumor is calcified. Can use CUSA or the bony CUSA, but the bony CUSA is very, very harmful. I prefer a traditional CUSA, not a bony CUSA, because the bony CUSA is very, very harmful for the blood vessel. Still, there is a calcified portion between the carotid bifurcation and the right optic nerve. Try to compress it by the CUSA again. Can use anything to remove the calcified part. You can use a micro scissor, you can use a CUSA, can using a crushing technique. Try to remove it as much as possible, but if there is any harmful about injury of any of the branches of the ECA or MECA or carotids, you can leave a small residual follow-up or for the gamma knife. Like a bone. There is a small steel part at the distal A1 added into the distal part of the A1. I try to remove it. As much as possible, but do no harm. That's a small residual at the junction between A1 and A2, lateral to the optic nerve. That's a follow-up MRI. Still, there is a small residual follow-up at the junction between A1 and the A2. Like this, small residual at the junction between A1 and the A2 was left behind to save the life of patients. This case, as mentioned before, was a small prechiasmatic craniopharyngioma operated through the fronto-lateral approach. There was a small residual and the recur after that, and I used a terminal approach and I opened the lamina terminalis to deliver the tumor. The Sylvian fissure was opened on the left side. Here's the carotid bifurcation. The left optic nerve was swollen by the tumor because the tumor was retrochiasmatic, pushing the chiasm, very, very short chiasm. In the first surgery, it was prechiasmatic, but after months, there is a few months, there is a change in the behavior, and the tumor became retrochiasmatic, infiltrating the left optic nerve, and I opened the lamina terminalis, and I decompress the tumor from the translamina terminalis corridor. Also, can use the CUSA microtip to debulk the tumor. Also, care should be taken not to injure or to violate the A1 during working in the small corridor for the lamina terminalis. Also, the preservation of the chiasmal blood supply is very, very crucial. Basal artery exposure. Either interior approach or, as mentioned before, this area, there is many blood vessels, basal bifurcation, SCCA, B, A, left infant oculomotor, right oculomotor. We must decompress the capsule and preserve all this structure as mentioned before. Another case is basilar artery, is a carotid bifurcation. Search for any residual above the basilar bifurcation. That is the oculomotor nerve between SCCA and the P1. Is a carotid bifurcation, M1, A1. PCOM is very large in this case. Search for any compressing cyst, compressing the oculomotor nerve. That is the right oculomotor nerve. Nothing was found. Another case, the liquid membrane was opened after debarking of the tumor from optical carotid triangle and searching for any residual cyst below it. For the complex craniopharyngioma, the mortality rate with my series was 4 cases, 16% from acute hypothalamic insult. Gross total removal was achieved in 54% only, with subtotal removal in 46 cases. Permanent DI was noticed in 75%, because in complex craniopharyngioma, you cannot find or you cannot dissect, or sometimes you cannot see the pituitary stalk, particularly with multiple surgery and the previous irradiation. In conclusion, the recurrence rate is very high but in the craniopharyngioma, particularly with when you operate on a large or complex or recurrent craniopharyngioma. Gross total removal or partial removal with adjuvant therapy is the best. And thank you very much for your attention. Thank you, sir.
Thank you, Professor Khaled El-Bahi, for this very important presentation. Now, I received many questions. Let me first welcome Professor Faiz Obaid, the president of the Jordanian Neurosurgical Society. He's already in the panel list. Dr. Faiz, are you here? Okay, I will say his questions. He is asking Professor Jenkins how to manage craniopharyngioma invading the cavernous sinus. That is the first question. The second question, and retrochiasmatic craniopharyngioma with prefixed chiasma.
Well, the first question was how to manage one invading the cavernous sinus. I've never actually seen a craniopharyngioma invade the cavernous sinus that I can remember. Compressing, yes, but not invading. I think the answer would probably be that, as with any tumor invading the cavernous sinus or occupying the cavernous sinus, that I would probably give in and give them radiosurgery to that area. What do you think, Professor El-Bahi?
For the cavernous sinus one, I was in Osaka with Professor Hakuba. Professor Hakuba was interested in the cavernous sinus. I did a review of literature and I read about more than 100 papers about craniopharyngioma, and I didn't find any extension in the cavernous sinus because the craniopharyngioma is an epiarachnoidal, very difficult to reach the cavernous sinus. But even the pituitary adenoma, okay, it can infiltrate and compress the cavernous sinus. So I am not imagining how the cavernous sinus be involved with the craniopharyngioma, because the craniopharyngioma is epiarachnoidal. and very difficult to invade the cavernous sinus, not like the pituitary adenoma. And if there is a review of literature on some reported cases, I am agree with you about the radiosurgery for this extension if it is present.
And the other question was about a craniopharyngiomas with a prefixed chiasm, I think. Is that right?
Yes, yes, that's right.
Yeah. Well, I think both of us have covered that to some extent. And again, just to say there's no correct answer. In general, it would be against an anterior interhemispheric approach, but I showed you a case where the chiasm was so low that in fact that was a very good approach. So I think once again, as I think both of us have said, you have to look at each case individually, and even for a subgroup like that, there's not one correct answer, and there's nothing that's going to be absolutely wrong either. Would you agree, Professor Harold-Bay?
Something you said before, that the relation of the craniopharyngioma to the dorsum celli. I am totally agree with you. If the tumor anterior to the dorsum celli, which is retrochiasmatic, you use the translaminar terminalis either by frontal interhemispheric or terional approach. Once the tumor extends beyond the dorsum celli and it is retrochiasmatic, I prefer to do transcallosal approach, as you mentioned before. I totally agree with you, the relation to the dorsum celli. So that sagittal MRI, high resolution MRI, sagittal CATS, FLAIR image to declare the relation between the craniopharyngioma and the optic chiasm and the dorsum celli is very crucial point to select the approach.
Okay, now we have another question from Dr. Ahmed El-Assar. What is the best approach? He didn't specify to which speaker, and I suggest that both of you answer the questions. Best approach for small craniopharyngioma with large pituitary gland.
In a small craniopharyngioma with large pituitary gland, I am asking about what about the symptom of this patient. If the patient is asymptomatic, follow up the patient clinically. If there is a symptom with a large pituitary adenoma and above there is a craniopharyngioma, if you perform it or from below endoscopically, you should mobilize the pituitary gland. But if the pituitary gland itself is large, I think the endoscopic approach may not be suitable. And if there is a symptom and you must decompress, you must perform a mini craniotomy like a frontolateral approach and use the translaminar terminalis corridor. But sometimes there is association between pituitary adenoma and suprasellar meningioma, between pituitary adenoma and the craniopharyngioma, so that high resolution MRI should be performed to take a decision. Complete hormonal profile should be performed. Visual acuity and the visual field should be performed to take a decision. I can operate or not, or you can, if there is no symptom, just to follow up and you can give the patient the gamma knife. If there is a symptom, you must decompress, but I prefer the labella terminalis corridor for this small craniopharyngioma if it is retrochiasmatic and associated with large or bulky pituitary gland itself.
Professor Jenkins?
I don't really have much to add to that, but I think I showed you one case of a small cystic craniopharyngioma with quite a large pituitary underneath. I agree that it's not a good idea to go transsphenoidally, and you'd probably be able to do just a simple terional approach for many of those. It depends on its relationship to the other structures, of course. So yeah, I think I pretty much agree.
Okay. Now we have question from Dr. Iman Abdel Karim. She didn't say the question, she is just raising her hand. Iman, I already unmuted you. Dr. Iman Abdel Karim. Okay, let us move to another question until she unmutes herself. This question from Professor Muhammad Al-Faqi, Honorary President of Egyptian Society of Neurosurgery. To Professor Jenkins, he has a question. To Professor Khalid, he has a question. Professor Jenkins, do you use extended endonasal approach for some patients?
Not for craniopharyngiomas. I've used it for meningiomas, but not for craniopharyngiomas so far. I'm not totally convinced by the takeover of the whole world by endoscopic surgery, and I tend to draw the line it's a little bit like, if I could make a parallel, when you've got a choice, you're doing a vascular case, doing an aneurysm, and your natural instinct nowadays is to do it endovascularly. And then the endovascular thing gets more and more and more complicated with 2 stents and cross stents and balloons and everything. And then you say, maybe I'll just put a clip on it. And it's a little bit like that when you've got something that would be really quite complicated and perhaps dangerous to do from below by an endoscopic approach. And actually it might just be easier to do a craniotomy. Then I would go for the craniotomy. And I'm not a great fan of the extended approaches, although, as I say, necessary for basal meningiomas sometimes.
Thank you, Jenkin. The other question to Khalid El-Bahi, would you show some of your cases? How long was the duration of follow-up? What was the incidence of recurrence?
I mentioned before the incidence of recurrence in my series was 22%. And the long-term follow-up not exceeded 5 years with me. But it may be more than 22%. Actually, I perform the case, and when there is a gamma knife, I take or share the gamma knife for the follow-up, and my recurrence rate was 22% in all my series, which exceeded more than 45 cases. And still follow up in my cases. I am follow them regularly.
Okay. Another question. How important is tedious, possibly dangerous removal of calcified adherent tumor parts to vital neural and vascular structures? Will we start by Jenkin and then Khalid?
I agree with Professor El-Bahi that you should make every effort to remove as much tumor as you can, but safely. And if you've got something that is strongly adherent to a vital structure, especially if it's calcified, then I would tend to leave it behind. But you can, particularly with some of the, we're now using the Sonopet instead of the CUSA. And I don't know whether many of you have got experience with that, but without it being very aggressive, you can actually shave more calcified, firmer tumors off surrounding structures more accurately without causing any damage. And I've actually gone back and operated on a couple of patients that I'd given up on and managed to do a resection using that instrument.
For me, I showed before a case of calcified meningioma, I prefer to use an original or ordinary CUSA because the Sonopet may be harmful, particularly for the AC complex. So that if there's a calcified part, I try to remove it. But if this calcified part was adherent to the floor of the third ventricle, I may violate the floor of the third ventricle, and I will lose my patient. And if there is a small residual at the carotid bifurcation or around the recurrent artery of Hofner, I try to dissect it. But I don't like to use a Sonopet in this area, particularly because I was afraid for the perforation or vascular injury. If there is a small remnant and we have the option of the gamma knife, I better to be conservative for these cases.
Can I pay comment, Mr. President?
Professor Osama El-Ghandour, Professor of Neurosurgery, Azhar University, former Dean of the Faculty of Medicine, Azhar University, and Honorary President of the Egyptian Society of Neurological Surgeons. We would like to welcome you in this webinar and thank you for contributing by discussion. Please go ahead.
Thank you very much indeed. I would thank both of the speakers, especially Mr. Alistair, who it seems has a red eye, and in spite of that, he came into the webinar. We thank him very much indeed. I just
well spotted.
Oh, thank you very much indeed for that. I just, I'm glad to hear that you do the transcallosal approach, because I used that.
It's 16 hours.
Once we thought it's a colloid cyst, although my argument it was a craniopharyngioma. It was totally.
Dr. Nasser, can you communicate with me?
Yes, yes. Professor Osama El-Ghandour.
I'm with you. I'm with you.
Okay.
We thought it's a colloid cyst, but turned out to be craniopharyngioma. So transcallosal approach is an excellent approach, but providing that the tumor is bulging through the foramen of Monroe and widening the fornices of the around the foramen of Monroe. One thing also I just wanted to say, recurrent craniopharyngioma is not always into the same place. I had once into the CPA, I think you mentioned that as well in your paper, and I had one penetrate through the pons and went into this fourth ventricle. And I took it from the fourth ventricle, and the other one I took it from the CPA as like an acoustics. The last thing I just, not the last really, the diabetes insipidus, there's some exaggeration about it because people, they make it iatrogenic. My rule is I allow the patient to drink as much as he can. And then if he still brings more than 5 liters per day for more than a few days, then I start to give the vasopressin. Otherwise, I would not give him that. And as regards endoscopic from transsphenoidal approach, mind you that the craniopharyngioma does not dilate the cella, except not more than 5%. They don't really dilate the cella. So we have a very narrow corridor that you can't excise the whole tumor from there. And but some people, they go anterior and keep drilling of the anterior part of the cella and part of the ethmoid as well. Otherwise, you can't drill. So, and even in doing that in large craniopharyngioma, you cannot excise it at all. So the best approach is, according, as you mentioned, the trional, the transcallosal, the subfrontal, the interhemispherical, whatever, according to the direction, and to choose the shortest trajectory of the for the tumor. Thank you very much indeed, Professor.
Thank you, Professor Osama. Jenkins, do you want to make a comment?
Well, I just, I think it's very nice when you have a seminar like this, that everybody's agreeing with each other. But I think what is interesting about this is that I think craniopharyngioma is almost unique because there is no correct answer. Every tumor is different. Every tumor has a different consistency, a different site, and a different approach. And we will never master this. But one thing for certain, that unlike the vascular cases I mentioned earlier on, we will always have this. There's not going to be a non-surgical solution to this tumor for a very long time, I don't think. So we still have our fun.
Khalid?
Thank you, Sir. How are you?
Okay, let us now move to another question. This question is from Dr. Muhammad Nasr. Actually, he has 2 questions. The first question, during terional transsylvian approach, is it necessary to identify the recurrent artery of Hobner?
Yes, because most of the problem with opening of the sylvian fissure and they deal with the retrochiasmatic or suprachiasmatic craniopharyngioma is the adhesion between the cyst of the tumor and the perforator from the A1 and the A2, and the most important is the recurrent artery Hobner. We must preserve it, and we must know the variety of recurrent artery of Hobner. Most of the cases posterior to the main trunk of the A1, but some cases it is more anterior and adherent to the capsule, so that care should be taken during the dissection not to injure the recurrent artery of Hobner, otherwise you will lose your patient.
I completely
Jenkins?
agree. And I think that's the whole essence of this operation, is to recognize and preserve every normal structure, because as you say, you will lose your patient otherwise. I noticed that you've another question, which was, from which side do you approach the tumor?
Yes, that is the second question, you see.
Yeah, side with worst vision or
Let me
side?
say the question, Jenkins, from which side to approach the tumor? From the side of the worst vision or from the opposite side?
I think there are two. Let's take the pterional approach, because that's really the approach you're talking about if you're going unilaterally. What you will find sometimes is that the tumor will have done some of the dissection for you. In other words, it will have enlarged one of the windows, usually the opticocarotid window. And that is the side that I would choose to approach it from, because then I will have more space to work in. But otherwise, then yes, obviously you would tend to use the side with the worst vision. Very occasionally you have a side with no vision, and of course you've then got more leeway.
May I just add a little bit thing? You allow me, Professor Nasser, to
yes,
add?
Yes, of course.
Yes, I mean when you go to the right side, usually you compress the left optic nerve much better than right side. And when you go to the left side, you decompress the right optic nerve. So if you have a bad right vision, the right optic nerve, you go to from the left, you would really do excellent decompression. And if you have a left optic nerve bad vision, you go to from the right, you will really, I'm talking about the pterional approach, you will really decompress the opposite optic nerve, which is the left, which is a bad vision. Much better. Thank you.
Khalid?
I am totally agree with Dr. El-Ghandour, because the merit of the pterional approach is to control the contralateral side. If they have a prechiasmatic craniopharyngioma, you can operate from the, or can see the contralateral side from the pterional better the ipsilateral side. Particularly if you have a retrochiasmatic part. The problem with the retrochiasmatic craniopharyngioma with the pterional is dissection of the ipsilateral side from the third ventricle. You can use the microscope to dissect it from the contralateral side through the pterional. You can see everything, but from the ipsilateral side for the retrochiasmatic, it's better to combine it with the endoscopic assisted surgery. The pterional approach, I love it. And I think all of the people love the pterional approach. You can reach anything by the pterional approach. You can see the basilar arteries, the basilar bifurcation, B1 oculomotor on the both sides. And you can see the liqueous membrane and even the pituitary stalk. I think I prefer it than the bifrontal approach, or even the mini craniotomy or the frontolateral approach.
Okay. I think we have the last question from Dr. Muhammad Amin Kamali from Yemen. He is asking, what about small asymptomatic craniopharyngioma? Jenkins, would you start, please?
Yes. Well, of course, it does raise the question about how you found it in the first place. Is it really asymptomatic? Why did they have a scan? But if you really do find a small asymptomatic tumor, it's one of the, I think, the golden rules of neurosurgery, as I have become a little older, is I don't think I've ever seen a really good result from operating on an asymptomatic patient. We find asymptomatic lesions all the time, whether it be pineal cysts, Chiaris, etc., and don't operate on them unless you need to. So in this case, I would simply follow it up with serial scans. And in fact, I have a case like this, which I am going to operate on about 5-6 years after it was first shown. And she's going to be operated on soon. But what's happened with that one is it's done what I've just said. It's still at a size which you can operate on it very easily, but it has enlarged enough to increase the size of the window that I'm going to approach it through. And so the tumor's done some of the work for me without getting out of control. So the MRI scan is your friend, and use it.
Khalid?
I prefer follow-up clinical and radiological follow-up, but be sure that it's not a hypothalamic hamartoma. If it is a hypothalamic hamartoma, I prefer to give a gamma knife for this patient, particularly if there is a precocious puberty and so on. If it is craniopharyngioma, please don't touch the patient and follow up clinically and radiologically.
Well,
Professor Osama?
I beg to differ a bit. I mean, craniopharyngioma probably producing subtle symptoms like delayed puberty for 3 or 5 years. He is unaware. There is no symptoms to him, but just delayed puberty. Why should I wait till the tumor destroy the whole hypothalamic pituitary axis? I will operate on a small tumor rather than a tumor which is too large, going into intricate, insinuating itself here and there. Well, why then I wait till he become really hopeless of having any pituitary hormones. Thank you.
Well, yeah, all I was suggesting was you wait until you see even a few millimeters of growth, but you don't wait till it gets out of control. I just feel that you have to have some evidence that the tumor is actually causing harm. And you said yourself there, this is not an asymptomatic tumor. And the patient has probably been investigated because of delayed puberty. And then you've got a totally different situation.
In our countries, delayed puberty is not a symptom, but really it's a symptom being a neurologist or neurosurgeon. They don't care about if he's delayed puberty for 2 or 3 years, but he in fact is symptomatic, but they take it, you see the illiterate people, they take it as asymptomatic, but in fact, if you go carefully and scrutinize the history, you will find a real delay of the puberty. Thank you.
Thank you.
Thanks. At the end of this session, I would like to thank our great professor and my close friend, Professor Jenkins Alistar, President-elect of the British Society of Neurosurgery. Thank you for honoring us by contribution to our webinar. We are looking forward to have more collaboration in future webinars. Thanks to Professor Khalid El-Bahi, Secretary of the Egyptian Society of Neurosurgery. Thanks to Professor Osama El-Ghannam. I would like to thank all participants. Sorry for this delay, about 12 minutes, but really it was a great session with very interesting discussion. Thanks to Utopia for organizing this webinar. And let me announce about next Friday, we will have Robert Spetzler speaking. We will have a session about cerebrovascular and endovascular neurosurgery with Professors Tamer Hassan and Ala Habib. Thank you very much for this very interesting and very successful webinar.
Thank you very much for inviting me. I've very much enjoyed it myself, so thank you. And I look forward to seeing you soon.
Next Friday will be the feast.
I know, but we just discovered this yesterday, and it is very late to make any changes because Robert Spetzler confirmed his contribution maybe like 1 month ago. And so we were surprised about this yesterday. And so we will make it at the same time. And Professor Osama, you will be one of our participants. I'm saying from now.
No problem. We'll eat the meat and the meat.
It's our pleasure.
Thank you, Professor Jenkinson, for your nice and elegant presentation and competent opinion. And we will meet again and again. Thank you very much. Thank you to Professor Dr. Osama El-Ghannam for his elegant comments about our presentation. And thank you, Professor Nasser El-Ghandour, for this great job. And thank you to all of the people. And next week we'll eat the meat and eat the meat. Thank you very much again, and we'll
Thank
meet
you.
next week, inshallah.
Thank you very much. Thank you, Jenkins. Goodbye. Goodbye. Thank you.